We're going to cover a lot of ground in today's talk because the serrated pathway to colon cancer is underappreciated, underrecognized, but extremely important to colon cancer prevention in today's landscape. Now, no two colorectal cancers really have the same molecular or genetic signature. It's a very molecularly heterogeneous disorder. However, we broadly recognize three pathways that lead to colon cancer. The most well-known one is the conventional chromosomal instability pathway, which is basically the classic adenoma to carcinoma sequence, in which there's an APC mutation at the beginning of everything, leading to an adenoma which progressively acquires progressive genetic alterations, eventually leading to cancer with a somewhat specific signature. These cancers tend to be microsatellite stable and not to have high levels of SIMP. SIMP refers to methylation of the CpG island or SIMP phenotype. And these cancers tend not to be hypermethylated. The second pathway is the mutator or microsatellite instability pathway, which is exemplified by the Lynch syndrome, in which you have germline mutations in the mismatch mutation repair genes, leading to a cancer that's actually hypermethylated and microsatellite unstable. Together, these two pathways, which are really adenoma-based, contribute about 2/3 of colorectal cancers. So a big chunk of remaining cancers are accounted for by the serrated pathway. There are several molecular underpinnings to the serrated pathway, some of which are not as well defined as the others. I will focus on what I'll refer to as the main serrated pathway, and this one really goes through the central actor, which you'll see this theme in this talk later on, the sessile serrated polyp, which should be thought of really as an adenoma equivalent in terms of its risk of colon cancer. This pathway starts usually with a BRAF activating mutation. BRAF is an anti-apoptotic gene. And these lesions, when they form the sessile serrated polyps, they're prone to hypermethylate. And when this hypermethylation is nature's way of silencing genes epigenetically without really altering the code of the gene itself. When this hypermethylation hits a critical gene, say, for example, MLH1, which is one of the mismatch mutation repair genes, this gene is silenced, leading again to a SIMP-high microsatellite unstable tumor. Again, but these cancers, although they have a comparable molecular signature, are different because the gene itself is not mutated, it's epigenetically silenced. To get our nomenclature house in order, first and foremost, the WHO has updated the classification of serrated class polyps in 2010, and this is really what we should all be going by. There are three major classes of serrated polyps. Hyperplastic polyps with three subdivisions here that are distinguished molecularly and histologically, but really have no relevant clinical correlates at this point. Hyperplastic polyps are considered benign lesions. The more relevant ones from our standpoint are the sessile serrated adenoma or sessile serrated polyp and the traditional serrated adenoma, and both of these lesions are considered premalignant. SSA/P is somewhat cumbersome to say, and those terms are interchangeable, but for the remainder of the talk, I will be preferentially using the term SSP to avoid any confusion with conventional adenomas. And these lesions can also have cytologic dysplasia. Briefly, hyperplastic polyps and SSPs can be distinguished histologically. In hyperplastic polyps, the crypts are elongated and straight with narrow bases. Proliferation occurs in a somewhat orderly manner. The proliferative zone is in the lower third of the crypt, and then the serration occurs in the luminal aspect. With sessile serrated polyps, this proliferative zone, which is in the lower part of the crypt here, is actually displaced laterally. So the crypt grows laterally in different directions instead of going cephalad towards the lumen. The crypts are dilated and branched, and they may be filled with mucin because there are usually goblet cells within these crypts. You see the endoscopic correlate of that as the mucus cap, which is often a clue that there's an SSP when you're doing these exams. Now, that's great when I show you highly selected images of really characteristic changes. In reality, it's often difficult to distinguish hyperplastic polyps from SSPs because these changes can be either very subtle or very scarce. So practically, there's a lot of inter-observer variability in distinguishing these two types of polyps, even among expert pathologists. And this has led to, it contributes to the high variability in the endoscopic detection rates reported in studies looking at serrated polyp detection. Now, pathologists are doing better. There are studies showing that SSP diagnoses are actually increasing over time. However, the variability persists. And in studies where you get blinded pathologists to clinical and previous histologic interpretations, and ask them to reinterpret slides of polyps that were labeled as hyperplastic before, these pathologists tend to rebrand those polyps as SSP if they are in the right colon or they are of larger size. So the practical bottom lines to take from this slide is really keeping, you should probably do that for all types of polyps, but it's particularly important for serrated polyps. Communicate with your pathologist, make sure you're on the same page with regards to the criteria that are being used to call these, and treat all right-sided, apparently hyperplastic polyps that are larger than a centimeter as an SSP from the standpoint of what you're going to do for post-polypectomy surveillance. These polyps can be, of course, there's overlap in endoscopic features, but broadly, there are some distinguishing characteristics. Hyperplastic polyps tend to conglomerate in the left colon, particularly in the rectosigmoid, and be diminutive-sized and usually disappear with insufflation. The sessile serrated polyps have more characteristic appearances, and many times they're larger, located in the right colon, and covered with a telltale mucus cap, which is sometimes the only clue that they're present. But they can also be characterized by other telltale signs, which I have to emphasize are fairly subtle. So a high index of suspicion is required to locate these, such as a rim of debris or bubbles highlighting the polyp, alteration of the contour of a fold, or interruption of the underlying mucosal vascular pattern. And there's more and more research that you can actually distinguish these two types of polyps by focusing on their morphologic characteristics. So the presence of indistinct borders, a cloud-like appearance within the polyp, and dark spots inside the crypts are associated with an SSP histology as opposed to the benign hyperplastic polyps. Why is this so important? Well, sessile serrated polyps, and that's one of my take-home messages today, are really an important screening relevant lesion. First of all, their prevalence is higher than we used to think. Most recent studies that have expert endoscopists working with expert pathologists in various settings put that prevalence rate at about 8 to 9% in colonoscopy studies. And 5 to 8% of these have cytological dysplasia, the more dangerous subtype of sessile serrated polyps. The other thing to keep in mind is that these lesions have characteristics that overlap with post-colonoscopy colorectal cancer, so interval cancer diagnosed soon after colonoscopy. They tend to be located in the proximal colon, and they have a comparable molecular signature. They have microsatellite instability, and they're associated with SIMP. The other thing to keep in mind with regarding SSPs, and I'll show data about the cancer risk associated with individual polyp subtypes, is that they seem to alter the milieu of the colon so that you end up with a field effect that promotes colorectal carcinogenesis. And there are several lines of evidence pointing to that. When you scope somebody with and find sessile serrated polyps, there's the odds of finding other dangerous lesions, so advanced conventional adenomas, is increased, at least by a factor of 2, as shown in this meta-analysis. And that odds are increased even further if the sessile serrated polyp is proximal and or large in size. These lesions also increase metachronous colon cancer risk on follow-up. In this long-term follow-up of patients who were enrolled in the original flexible sigmoidoscopy, Norwegian flexible sigmoidoscopy randomized trial, they brought back patients that had serrated polyps detected at the original examinations and invited them to undergo repeat colonoscopy, and then compared these to patients who had no polyps at baseline. The hazard ratio for cancer for patients who had large serrated polyps at baseline was increased and was really comparable to those that had conventional advanced adenomas. Very interestingly, despite this increase in cancer risk, it didn't seem that it was necessarily related to individual polyp risk. So they had a group of patients that had large serrated polyps that were found at screening many, many years ago in the 90s that nothing was done about because we didn't know any better back then. And of those 23 large serrated polyps that were left in situ for about 11 years, none of these developed into cancer. So you do see increased cancer risk, not necessarily related to the individual polyps. But what is the risk associated with individual polyp subtypes? I think the most elegant and direct evidence comes from this population-based, recently published Danish study, which basically retrieved the records of a large group of patients who had undergone colonoscopy, and then re-reviewed the pathology of apparently hyperplastic polyps by expert pathologists using the WHO criteria. And then they estimated the risk of colon cancer over a 10-year follow-up period. And look at the results on the right side of the table here. Patients who had sessile serrated polyps without dysplasia, sessile serrated polyps without synchronous adenomas, sessile serrated polyps with synchronous adenomas, and conventional adenomas without serrated polyps all really had very comparable 10-year risk of colorectal cancer. Actually, you might argue that the risk with sessile serrated polyps was slightly higher than that of conventional adenomas at baseline. Patients who had sessile serrated polyps with dysplasia and those with traditional serrated adenomas had markedly increased colorectal cancer risk over a 10-year period, and confirming again that hyperplastic polyps only at baseline do not confer significantly increased colon cancer risk. Perhaps the most extreme manifestation of this serrated milieu and field effect is exemplified by the serrated polyposis syndrome. This is also defined by the WHO. I'll go over these criteria, but emphasize first that these are largely empiric criteria based on phenotype, what you actually find in the colon. Despite the name polyposis, which suggests a direct genetic cause, there is as of yet no identified gene that is directly implicated in SPS. Nevertheless, the criteria are you should meet at least one of those criteria. At least 5 serrated polyps proximal to the sigmoid, of which at least 2 are 10 millimeters or more in size. At least 1 serrated polyp proximal to the sigmoid in the first degree relative of a patient with serrated polyposis syndrome, and more than 20 serrated polyps throughout the colon. Now, SPS is really under-recognized in clinical practice. This study comes from my colleague, Doug Rex. He had 529 patients referred for large polyp resection. 20 of these ended up being diagnosed with serrated polyposis syndrome, but 19 of those 20 were unrecognized by the referring endoscopists. Now, the actual population prevalence of this disorder is not known, but every time I look at the study, the rate reported is higher. And the most recent estimates in fecal occult blood test screening cohorts put it at between 1 to 111 colonoscopies to 1 in 127 colonoscopies, and 1 to 238 in screening colonoscopy cohorts. Of course, these studies are prone to various types of biases, but regardless of where the real numbers are, this dwarfs any other polyposis syndrome prevalence rates. As I said, the genetic basis is unclear. It really is an unusual syndrome. You see signals that it has a genetic component and others that go really against it. What goes against it is that criterion number 2, remember that's the one where you diagnose it based on family history. Diagnosing serrated polyposis syndrome based on that criterion alone is actually not that common of a situation. Typically, it's the other 2 criteria that lead to the diagnosis. And the other is the average age of diagnosis is usually more than 50 years, which goes against, again, a genetic disorder. And finally, unlike the other more classically known polyposis syndromes, there aren't any established associations with extracolonic cancers. However, about 50%, in some studies even more, of patients report a family history of colorectal cancer. So there's definitely a signal there for clustering, familial clustering of cases. It's regardless of whether or not there is an important genetic underpinning to SPS, it's very important to know that this is a dangerous disease and it is associated with an increased risk of colorectal cancer. Several cohorts, predominantly from European studies, have attempted to quantify that risk. And in these 2 studies, cancer diagnosis was established in 16 to 29% of patients with SPS at an average age of 54 to 61. Very important. We talked when we talk about sessile serrated polyps. I think we tend to overfocus on the proximal colon. In the case of serrated polyposis syndrome, again, it's a field effect. Don't forget about the left colon. These studies showed that the distribution of cancer in those patients is almost equal between the right colon and the left colon. And various criteria can help you predict which patients are at highest risk. The presence of serrated polyps, sessile serrated polyps with dysplasia, the concomitant presence of advanced adenomas, and having both WHO criteria 1 and 3 present together are all associated with colorectal cancer risk. The good news is that this colon cancer risk appears to be front-loaded. Most patients are diagnosed at the time you actually diagnose serrated polyposis syndrome. And the cumulative 5-year incidence is lower, 1.5 to 1.9% in these studies. The most important clinical point about serrated polyposis syndrome, really recognition, high index of suspicion. And keep in mind that colorectal cancer risk is highest at the time of diagnosis. In series that have followed these patients over time, there are good news. If you exclude patients who need surgery at baseline just because they have a cancer at the time of diagnosis, or the polyp burden is so high that there is no way but to send these patients to surgery, if you exclude these patients from the SPS cohorts, endoscopic control is actually feasible for most patients. More than 90% don't need surgery on long-term follow-up and requires an average of 2 colonoscopies for complete clearance in the situation. And clearance and effective surveillance are actually associated with measurably decreased colorectal cancer risk. So all of these emphasize the take-home points here. In addition to recognition, it emphasizes the importance of a high-quality baseline examination, referring these patients to an endoscopist with expertise in managing these patients, and to consider screening of first-degree relatives in a manner analogous, actually, to having a family history of colorectal cancer. So we generally recommend these for the degree relatives to undergo colonoscopy starting at the age of 40. The best test for SSP detection, switching gears here a little bit regarding optimizing detection and resection, really it is colonoscopy. A lot of data have shown that other tests really don't allow you to effectively find these polyps. FIT has low sensitivity for SSPs because these lesions tend not to bleed very much. Fecal DNA, because it has a methylation assay, performs better than FIT and is probably the best non-invasive test as far as sensitivity goes, but it's still around 40% for large SSPs. And as you might expect, CT colonography is outperformed by colonoscopy by several factors. And the reason for that is it's just not well adapted to detect polyps that have the very same morphologic features associated with SSPs, so proximal location and flat morphology. And finally, sigmoidoscopy-based strategies don't work very well. Again, we're talking about a polyp with right colonic propensity, and distal colorectal polyp features actually do not predict the presence of these polyps in the more proximal colon. So what are the things that really optimize detection of serrated polyps? This really aligns with what Dr. Shaukat just mentioned. The same things that work for adenomas work for serrated polyps. So it's really doing an obsessive compulsive exam and looking again, doing a very meticulous fold examination. The reason for that, you see that because there's a strong correlation between ADRs and proximal serrated polyp detection. And we know that longer withdrawal times are actually associated with improved proximal serrated polyp detection, especially as you increase your withdrawal time above 6 minutes. With this study really shows the law of diminishing returns, though. You don't prolong it indefinitely, and you kind of reach a plateau as far as serrated polyp detection is concerned at 9 minutes. Ancillary technologies, we don't have very good data because most studies look at serrated polyps as secondary analysis of other outcomes, looking at adenomas predominantly. But from what we know, high definition and electronic chromoendoscopy don't afford really a clear benefit as far as detection is concerned. Dye-based chromoendoscopy, spraying the mucosa with indigocarmine, may benefit. However, it's quite cumbersome and is not really, is unlikely to gain traction specifically for this outcome in mind. We said electronic enhancement may not increase detection, however, it optimizes resection of serrated polyps. And really the single most important factor here is making sure that you've clearly identified lesion margin to ensure complete resection. You can accomplish that with submucosal injection of, with a contrast agent or using electronic chromoendoscopy. You'll see here a really subtle finding in the colon, a small mucus bleb, which some endoscopists may resect only that portion or, heaven forbid, just biopsy or even ignore it altogether. But if you use your electronic enhancement, lo and behold, you'll see that really this was just the tip of the iceberg, the mucus bleb here, and there's a lot more polyp that was otherwise hardly visible with standard white light. Why is that important? Well, the CARE study, which was mentioned in one of the previous talks, really it was geared to quantify the risk of incomplete resection in practice, showed that SSPs were a particular vulnerability as far as completeness of resection is concerned. The risk of incomplete resection of SSPs in that study was 4 times higher than adenomas, and nearly half of large serrated polyps were incompletely resected. Now, in that study, I would say conventional standard techniques were used, standard hot snare resection, used blended coagulation. More recent studies show that when you use a more dedicated, specific, standardized approach, using EMR for smaller sized SSPs, you can actually optimize resection. And so you would do an EMR for polyps starting even at the 10 millimeter size range. And the key thing here is adding a contrast agent to the submucosal fluid, methylene blue, indigo carmine, whatever you have available. Other things, I'll show a video in a second to illustrate, other things that can optimize resection are using stiff snares and tight squeeze before resection, although there aren't really any comparative studies to prove that these methods are superior. This leads to optimized outcomes. In the Indiana University experience, when you use this methodology at follow-up after 4 to 6 months, the residual polyp rate for SSPs was no different than that of adenomas of similar size. In a larger study from Australia with 300 SSPs, larger size in this instance, the eradication rate of SSPs was much better, significantly better than that of adenomas. Intraprocedural bleeding was less than adenomas. Delayed bleeding and perforation were not significantly different. And probably this is the most important outcome. 2-year cumulative recurrence rate was 7% for SSPs, 4 times less than adenomas of comparable size. We'll see here a video that kind of sums up many of these concepts. How you can appreciate on the left lower side of the screen a alteration in the contour of a fold, very subtle there, SSP as it turns out. So this is really the value of the injection. It's not just to provide a submucosal cushion for safe resection, it's really to delineate lesion borders. We'll switch here to a stiff 20 millimeter snare. Works really well for this type of lesion, optimized resection. So I'm intentionally manipulating the polyp here to show you that there's the amount of injectate you put is not that important. You're going to end up with a lot of blue on the side here, and that's great because it shows you that you've really delineated the borders quite adequately. And then you'll close the snare very tightly on the polyp. You're going to have a rim of normal tissue. It's okay. That's actually more insurance that you've completely resected the polyp. Ask your technician to really squeeze the polyp very hard to separate it, and then remove it using primarily a cutting current. And you'll optimize resection here. There's a little residual on the left lower side, which was very easy to resect using a small snare. To wrap it up, surveillance guidelines or recommendations. As you might imagine, several societies have issued recommendations for surveillance of serrated polyps, and of course there is some variability between these recommendations. All of these of course, assume that there's a very high quality baseline colonoscopy, resection was complete, and bowel preparation was optimal. Now, the variability between recommendations really concerns the lower risk serrated polyps, small hyperplastic polyps or small sessile polyps. But they are all in agreement about the more dangerous types of serrated polyps. So, sessile serrated polyps that are larger, more than 10 millimeters, those with cytological dysplasia and traditional serrated adenomas these patients should undergo surveillance colonoscopy in 3 years in a manner akin to advanced adenomas on the adenoma side of polyps. So the take-home points are, I hope I've at least convinced you that SSPs are important lesions, that they are screening relevant, and that the colon cancer risk associated with them is comparable to that of conventional adenomas. Communicate with your pathologist, make sure you're on the same page with regard to the criteria that they are using to call these polyps. Learn to recognize their endoscopic features beyond the mucus cap. They can be very subtle lesions, as you saw. A high-quality examination trumps technology. It's the most important factor, really, to optimize detection. Be vigilant for serrated polyposis syndrome. Know those criteria by heart. And pay attention, especially in patients in whom you are actually finding several serrated polyps during an examination. Look carefully, go back to the previous procedure reports. You might uncover some SPS cases that were previously unrecognized. Use a standardized EMR technique using a submucosal injection with a contrast agent, which is, again, crucial to delineate lesion border. And the size limit here is lower than what we would do for EMRs of conventional adenomas. And finally, recognize the higher risk serrated lesions because these require more intensive surveillance. Thank you for your attention.